The following are 3 clinical tests which are overused and overinterpreted in an acute hospital setting. They are non-specific and they often cause delays and uncertainty in management rather than progression. Their use should be limited to specific clinical circumstances, which I will highlight. Now, without any further ado, here they are. Sitting at number 1 is a D-dimer, which should only really be used in disseminated intravascular coagulation. I cannot remember the last time I did a D-dimer. Clinically, if you are worried about an acute PE or a DVT, then proceed to do a CTP or Doppler. Almost anything can cause a high D-dimer, and a low or normal D-dimer does not rule out a blood clot. Now, an acute DIC is widespread abnormal clotting of the small blood vessels throughout the body due to an acute insult such as sepsis, trauma or surgery. This leads to rapid consumption of clotting factors, leading to a significant bleed. Here are 5 clinical points. A raised INR, a raised APTR, a raised D-dimer, a low fibrinogen and a low platelet. Here are 3 steps in their management. Treat the underlying cause. Discuss with a hematologist because the patient may need platelet transfusion or fresh frozen plasma. Number 2 is an abdominal X-ray. I also cannot remember the last time I did this test. Always do a PR exam before abdominal imaging because the diarrhea may be overflow. If the patient is acutely unwell with abdominal concerns, then proceed to an urgent CT and inform the surgeons. Remember, an acute abdomen can present without peritonism or high lactate. If there is disproportionate abdominal pain or distension, raised inflammatory markers or fevers, then have a low threshold. A lack of acute signs on abdominal X-ray does not mean there is not an acute abdominal pathology. Also, the patient's abdominal pain may be due to another non-bowel related pathology which will not show up on the abdominal X-ray, such as acute pancreatitis, acute cholecystitis, gallbladder perforation, etc. Number 3 is a troponin, which should only be done in acute MI or pericarditis. Do not do a troponin routinely for chest pain. Only do one if the chest pain sounds cardiac or there's ECG changes. Interpret the troponin with caution if there's an insult to other organs such as an AKI, heart failure, pneumonia or sepsis, because this will cause a non-specific rise in the troponin. If the troponin is not significantly high or repeat levels do not show a significant rise, then refrain from a cardiology referral. Treat as a type 2 MI. The number of referrals cardiologists get for type 2 MI is... So remember, doing these clinical tests is not forbidden fruit, but should only be done under specific clinical circumstances. Focus more on developing your clinical acumen with practice, practice and practice. And always, don't forget to subscribe.